Okay, hello everybody. My name is Anssi Auvinen. I'm a professor of epidemiology at Tampere University, and I was asked to talk about health risks from 5G. Professor Kilkki already told you something about the topic, and my perspective is more like human health risk assessment. I'm a professor of epidemiology, but still have nothing to do with, or very little to do with the corona epidemic. Epidemiology in general is about disease dynamics in populations, human populations, and my expertise is more in the area of cancer research. But I have a presentation that I could share with you. Just a moment. I'll just close those applications that I'm not needing, so that I could find my talk. Sorry for the, here it is. Are you able to see my screen now? I hope so. As is the practice in the medical field, I'll start by telling about my background and endless scientific. I've been involved in two major studies, the Interphone study and the more recent, still ongoing Cosmos study, in charge of the Finnish component, and a collaborator in the international study. Those two studies have received funding mainly from the public sources, but also from the industry, with proper contracts with that guarantee full scientific independence of the researchers. So I don't think they pose any real restriction into the studies. And also a member of numerous expert groups that have evaluated the health risks from mobile phones. So those might reflect my opinion or might be affected by those. What are more, something very little about the background, then about the approach in human health risk assessment. The main focus will be on risk of brain tumors in relation to mobile phones, very little about some other health outcomes, some summaries by expert committees, and then conclusions. I warned the organizers already that there's practically no human data available at the moment about the health effects of 5G, because the exposure has just been started, and all of the evidence that we have in the field of epidemiology, human health risks, is from the previous generations. So I'll try to make some comment towards the end of the talk. Epidemiology deals with human studies, human populations only, focusing very much on long-term effects, and I will not be talking about these short-term exposure lab studies, and I really focus heavily on cancer, which is my own area of expertise. As a way of general introduction, for human beings, for real human populations, we are not able to do what toxicologists do. So they have need experimental appropriate exposure level, usually very high requirements for similarity in the groups that they compare, so that they are using animals that are very comparable in each and every possible respect. So this is something that they are doing. I'm getting a message that my screen is not being shared. I'll give it a new try. Well, it says that my screen is being shared. Okay, so it's being seen. Very good. We have to do with what is available for us in the field of sort of real populations. We only observe people who are being exposed to agents, let's say lifestyle or occupational exposures or whatever, and then we just observe whether there are differences in the disease occurrence between various groups of people. And the main issue is nearly always is whether those people, for instance, that are using mobile phones extensively are similar to other people who are not using it at all or only using it to a lower extent, whether other factors that affect the risk of disease are similar. This will be called confounding. So basically influence of other factors, and then bias, which has to do with distortion of the results due to inappropriate selection of the study groups or lack of comparability in obtaining information from them. So basically the question in studies of mobile phones would be, are those people who use mobile phones, are they similar to those who don't use them or use them much less? The advantage, on the other hand, is that we are studying real human exposures, we are studying real human health outcomes, unlike laboratory researchers who are using typically very high exposure levels and observing outcomes that are not really comparable to human disease. So therefore, even if there's major uncertainty in epidemiological studies, they are fuzzy, they are involved not only biological level, which is far more complex than the physics level, but also behavioral aspects. But then anyway, the findings that we are able to see, they are readily applicable to human populations and human experience. So that is the strength. Obviously, why we are interested in mobile phone use has to do with the radio frequency electromagnetic fields, which I think you understand probably better than I do, but anyway, they are similar to X-rays and gamma rays, but lower energy levels, and other exposures are from base stations or radar or microwave ovens and so on and so forth. And also we have Wi-Fi nowadays, which is very low level, but then on the other hand, ubiquitous nowadays, we are always everywhere nearly exposed to Wi-Fi, so the low level but constant exposure might be equally important as the shorter duration exposure at higher levels from using a mobile phone. I'm talking about studies of the human exposures and human disease. What is a complication is that biologists and biophysicists have not been able to show any clear, credible mechanism that could induce health outcomes. And only thermal effect, the warming effect of radio frequency field is well established. The complication is for us is that we don't know how to define the most appropriate exposure. What is the measure that we should be evaluating? I think the specific absorption rate, SAR, is the best candidate, but as we don't know anything about the possible mechanisms, then this is no more than an educated guess. You'll probably know more about also from the technology of mobile phones than I do. Most important is their exposure when we are talking, when the phone is sending. The radio frequency field is mainly limited to the head when you are holding your phone to your head, and that is pretty much minimized if you use hand-free devices. And I think you've already covered the development of various networks from the first generation NMT in the Nordic countries to GSM to UMTS, 4G, and nowadays 5G. And for us who work with populations, the increase is incredible, where in 2 decades of time, the prevalence of mobile phone use have gone from 0 to practically everybody. Here are some data from the Finnish Ministry of Technology and Communications, so showing that starting from around 1980, at about 1%, the increase has mainly occurred during the late 1990s and early 2000s, and the next slide has the more recent data with leveling off after 2010, so that there isn't that much increase anymore, but the number of subscriptions exceeds by far already the size of the Finnish population. So there are more mobile phones than people in Finland nowadays, and the situation is very similar in many other countries. Very simple look, very crude assessment, of course, could be done by just looking at the trends. So we have the blue curve going up, which is the mobile phone subscriptions, and then we have the reddish line, which shows incidence of glioma, which is a malignant brain tumor among men. It's very stable. And then the whitish line going slightly up, which is the meningioma, which are the benign brain tumors, most common benign brain tumors, which is with some slight increase with time. So this could be an indication that, well, not much appears to be going on about the mobile brain tumors. But is this enough? Well, probably not. We know that brain tumors are very rare. There are only about 1,000 cases in Finland annually. And very few mobile phone users ever develop brain tumors. And of course, we'd like to know, even if we have those 1,000 cases in Finland, were those people ever using mobile phones? Did they use mobile phones more than the other people? Could this be somehow related to the mobile phone use? Did the tumors occur in the area of the brain that is most heavily exposed to the EMF field? These are very obvious questions. Of course, if there is a risk, we would like to know how large is it? Does it increase after 10 years, 5 years of use? How large is the risk? So this is not really enough, but we need to find out more about the possible relation between mobile phone use and brain tumor risks. And then I'll give a brief introduction to the epidemiological study types, because this is what I'll be addressing next. So the two most important types of studies that we use in this field are, one is cohort studies. The question is that we identify people who are exposed, for instance, using mobile phones, and then another group with lesser exposure or no exposure. Mobile in the health risks, health outcomes, incidence of brain tumors, for instance, between the two groups. Another approach is a case control study, where we are comparing people with the disease and people without the disease in terms of exposure. So that if people who have the disease are more exposed, have been more exposed, then I would suggest that there is an increased risk. We are not able to use randomized trials, which are used for medical interventions to cure people, for instance, because it would be unethical and impossible to expose people to mobile phones and deny some other people from using them. And cross-sectional studies where we only have sort of one single time point for data on mobile phone use and disease incidence doesn't allow us to really evaluate the dynamics, the relationship between the two. I will also make a reference to meta-analysis, which are pooled analysis combining data from different studies into one, sort of summing up all of the available research evidence. So cohort studies, very briefly, we are evaluating disease occurrence, typically higher incidence that should suggest an increased risk in the exposed group. We use risk ratios to evaluate this, and those studies would require very large numbers of people when we are assessing rare diseases such as most chronic diseases such as brain tumors are, and also long observation period of follow-up, which means the period for collecting data on disease outcomes. This is very logical, easy to understand for anybody that we are comparing, expecting to see an increase with the exposure if there is an increased risk. And the other type was case control studies, where we start from the disease. We first identify people with the disease, and then an otherwise comparable group of people without the disease, and then we start evaluating whether or not they have been exposed in the past. And more frequent exposure among people with the disease would suggest an increased risk. These studies are always retrospective in the sense that we are evaluating something in the exposure that took place in the past, and that this is a major complication in such studies. It's more difficult typically to evaluate something that has happened historically than concurrent exposures, and that is one of the shortcomings of case control studies. These are reported as odds ratios rather than risk ratios, but the interpretation is very much similar. The problems with evaluating past exposure is most obvious when we are using self-reported data on exposure. If we are asking people about, have you ever been exposed? Have you, for instance, when did you first start using mobile phones? How much did you use it in the five years ago or 10 years ago? And they're reporting such distant events, particularly if they are so sort of everyday events, is challenging. And the fact that you have been diagnosed with a brain tumor, for instance, might affect it. So that typically people with the disease are able to give a more complete account of their exposures because they're highly motivated. They pay attention to it. They want to find out why did they get the disease, while people without the disease, the controls, might not pay equal attention to it. And this is why case control studies are regarded as less robust than cohort studies. And the assessment of mobile phone use in epidemiological studies can be done in two ways. One is really to ask people themselves using questionnaires or interviews, and the other one is to try to obtain data from network operators. As I said earlier, we would like to have better, more accurate data such as SAR values, but there's not a single epidemiological study so far that would have been able to do it. So basically, questionnaire is that we are asking people about how much did you use, when did you first start using mobile phone, and that is pretty much, I always use the example that this is like asking people how many emails did you send 10 years ago. For me personally, I think it would be fairly impossible to give a detailed, accurate account of my behavior 10 years ago or 5 years ago. Typically, people remember their current practices and tend to report those, and it's far from accurate. And there is even empirical evidence to show that often the numbers of calls are underestimated and durations of calls are overestimated by a factor of 2. And the longer in the past you are probing, the less accurate the information tends to be. And yet another complication in this is when you are studying brain tumors, they would affect your brain physiology, your ability to recall, but probably at least as importantly, also your psychology. It's a major shock to be diagnosed with a brain tumor. And then if somebody, a researcher comes and starts asking you questions about your mobile phone use, that might seem very trivial and something that you might not put an effort into, particularly for malignant brain tumors. I think this has been covered by your previous lectures already to some extent. So basically, the power of the mobile phone is the main determinant of the specific absorption rate, the SAR. It depends on the network technology, so that typically the older generations induce higher SARs and use higher powers. Proximity to the base station is, as Matti Kirkki was saying, is also important. Calling while in transport is associated with higher power levels, rural areas also, and if you use hands-free device, that will minimize the exposure to the head. Okay, so this was the introduction, sort of epidemiology in 5 minutes. I hope you are still hanging on in there. So I'll go very briefly to the major studies that have been conducted. There are 3 major cohort studies, one in Denmark, one in the UK, and one international study. The Danish one is the oldest one, which has more than 400,000 people who had a private subscription to mobile phone network before 1996. Those people have been followed up for about 15 years, and the number of reports have been published evaluating several cancer types and neurological disease. The weaknesses include the fact that they have very thin data on mobile phone use. It's mainly ownership of a private subscription, so they don't have anything about work mobile phones, which were very common, particularly in the early days, and they don't have anything about the amount of mobile phone use. Also, people who bought private subscriptions in the early days, they used to be reasonably expensive, so they are probably different from the other people. In the UK, there is a large study of more than 1 million women attending mammography. They were asked also about mobile phone use, and they have been followed up for more than 10, nearly 15 years, and there's been one report about their brain tumor risk. They don't have any operator data. This is only self-reported, but it's sort of, they were asked about their current use, not history of mobile phone use. So the data is perhaps a little bit higher quality than in case control studies. And here is my liability, the Cosmos study, the cohort study of mobile phone use and health, where I'm involved. It's about 300,000 people currently from Sweden, Finland, Denmark, UK, the Netherlands, France. Established about 10 years ago, except France only joined us last year. Our advantage is that we have both questionnaires about, for instance, hands-free use, which cannot be obtained from the operators, but we also have call level data from operators about start and end time of each and every call received and made, so that this is objective, and this is, I think, the major strength of this study. But we are early days still. We have only 2 reports published so far, and the study is smaller than the other cohort studies. Here is a brief summary of what we know about the major studies published about the malignant brain tumors called gliomas, and there are 3 cohort studies that are in the upper panel. Actually, these are 2 studies. The men and women from the Danish study are shown separately, and the rate ratios are very close to 1, meaning that there would be no effect. Actually, slightly below. When we pool all these cohort studies, then the rate ratio is 0.92, and the confidence interval indicating the range that will be compatible with the data, going from 0.7, meaning less risk than for non-users, to 1.16, meaning that there would be 16% more cases. So cohort studies don't seem to indicate any excess. Case control studies are perhaps some more mixed bag. So we have the interphone study showing no increased risk, smaller French study with wide confidence interval, perhaps compatible with the range of possibilities. Korean case control study also small, not indicating any risk, but then a large Swedish study, actually a series of studies that would suggest that there is an increased risk of gliomas, rate ratio nearly 1.7, meaning that the incidence would be 1.7-fold among those who have been using mobile phones than the others. So this is where there is any suggestion of an increased risk. If you combine all of the case control studies, then there's some evidence that there might be a risk. If you combine both cohort studies and case control studies, the jury is a bit perhaps out still. So the rate ratio is 1.1, no material increase in risk, but there is disagreement between various studies, which is not uncommon in epidemiology. All studies have some uncertainties, and they might therefore, the interpretation is complex, and it requires very careful attention to the detail. What would be the sources of uncertainty, and how could they bias the results? If you go to meningioma, the benign tumors, the results are much more consistent. There's very little evidence that there might be any increase in risk of these benign brain tumors. So the pooled estimate is 1.03, very close to 1, which would suggest no effect on the risk of these diseases. And then finally, a benign tumor of a cranial nerve, acoustic neuroma. Here the results are very similar to glioma. Cohort studies show no excess, very close to 1 rate ratio, while case control studies again are more conflicting, with the Swedish study by Hardell suggesting that there would be more than 2-fold risk of acoustic neuromas, while the others are more closer to 1, suggest less indication of any risk. And similarly, when you pool everything, then the results are not very clear. The rate ratio 1.2-fold incidence of these benign tumors is something that mainly just calls for more research, more evidence, or then a good explanation about why are some studies reporting increased risk while others are not. Okay, then I'll move on to just very briefly outline the largest study about the risks by area of the brain. We know that the radio frequency field from the mobile phone is mainly, when you hold the phone towards your ear, is towards the frontal lobe and temporal lobe. So that is where you would be expecting to see an increase, if there is any, and not in the other parts of the brain. What we see here is that, okay, the rate ratio is about 1.1 for the frontal lobe, 1.1 for the temporal lobe, and slightly less for the parietal lobe, and slightly more for the occipital lobe in the back of the head. So there's no clear indication that the risks would be higher in the area of the head where the exposure is the strongest. Then I'll jump to an overall assessment by the International Agency for Research on Cancer, which is a WHO, World Health Organization, Cancer Research Institute. They published in 2012 an assessment about whether there is evidence for increased cancer risk from radiofrequency EMF, very heavily relying on the mobile phone studies, and their assessment that there is limited evidence in humans and experimental animals. The judgment was based on epidemiological studies of glioma and acoustic neuroma, the studies that I just reviewed. There was also a minority opinion in the expert group suggesting that we should call this inadequate evidence, because the cohort studies, which are regarded as the best level of evidence, and temporal trends do not show any indication of increased risks. And I can just show yet again a figure. Glioma incidence trend in Finland, this is only up to 2006. We also did an extended follow-up up to 2016, still no increase. This is very crude, very simplistic, but of course, if everybody is using mobile phones now for 10 years at least, and if there's an increased risk, you should expect that there would be a turn upward at some point of time. Similar results have also been published from the other Nordic countries, from the US, England, France, Australia, New Zealand, and Taiwan. So this is something that would be hard to explain if there is really an increased risk for the amount of mobile phone that people commonly use, for the 10-15 years that people have been using the phone so far. So there are, of course, limitations. Other health outcomes, this will be very brief. Neurological disease, these are the only studies, the only large, meaningful, good quality studies are from the Danish cohort, and they don't show clear increases in multiple sclerosis, which is a neurological disease. And similarly, for Alzheimer's disease and Parkinson's disease, the risks were actually lower among people using mobile phones, which might be related to the fact that they were probably wealthier, better educated, high socioeconomic group people. No differences in vascular dementia or amyotrophic lateral sclerosis, also known as Gehrig's disease. For some symptoms, there were slight increases in hospitalizations, vertigo, and migraine. That is very, very small increases and sort of hard to interpret. Sleep and memory, these have been mainly studied in adolescents, school children, young adults, and very commonly sleep difficulties have been more common in people using mobile phones more. There is one Swedish-Finnish study, the cohort study, the Cosmos study, another Swedish cohort, and a Chinese study, all indicating more common sleep problems in people with extensive use of mobile phones. This is very unlikely to be related to RF-EMF, more likely a psychological effect being aroused all the time and maybe using mobile phone at the night time, because the results are similar for 2G and 3G, and also in a Swiss study, the results were very similar for any screen time, not only mobile phones. For memory, well, there are only 2 studies that don't give much evidence, but could conclude that these are not affected by the RF EMF from mobile phones. Okay, where are we now? There is still major uncertainty due to weaknesses in the risk assessment. Mainly the weaknesses, the uncertainties stem from the fact that the data we have about mobile phone use is not really accurate and objective to the extent that we would like. I think the best source of such data are traffic records from the network operators, and this is why we have established the Cosmos study. So we hope that we will be able to improve the quality of the evidence from that study. And we are working on analysis of cancer risk, and we have planned also studies on Alzheimer's disease, Parkinson's disease, multiple sclerosis, and other health outcomes. So we hope to contribute to better level of evidence in the future. So basically, cohort studies and case control studies don't show strong evidence for increased brain tumor risk in relation to mobile phone use. The Swedish case control studies are maybe the only ones, but there's no consistent pattern or cross various studies, and even less for cohort studies that are regarded as a higher level of quality. Location of gliomas is not affected by mobile phone use. There's also a number of analyses that not all are clearly showing a lack of any effect. One very important piece of evidence, I think, is from the brain tumor incidence trends in many populations that don't show an increase, as we would expect had there been an effect of the mobile phones. Overall, my interpretation of the data is that after the 2012, the new studies that have been published are shifting the evidence more against an increased risk rather than the other way around. For diseases other than brain tumors, there is no clear indication of increased risks, but there are always uncertainties. Here is a summary made by the ICNIRP, the International Commission of Non-Ionizing Radiation Protection, and their view is that we do have extensive evidence from various research efforts, and most of them relate to brain tumors. And there are biases and weaknesses, uncertainties that make interpretation a bit complicated, but mainly there have been no increase in brain tumors associated with mobile phone use. So the overall, they conclude that RF exposure below thermal threshold is unlikely to be associated with health effects, but this remains to be updated with any future studies. And now I finally come to 5G, your area of interest. The question is, okay, we do have quite a bit of research evidence, but can we really apply to the new technology? Basically, this means, are the biological effects of 5G technology comparable to 2G, 3G, and 4G? We do have higher frequency band, which physics tells us results in less penetration in tissue, probably lower power levels. Also, there's different modulation, but nobody knows whether sort of a very unexpected turn of the events that there are major scares about 5G. However, psychology of risk perception does indicate that there are features that emphasize the fear by 5G, this is something that is new or unknown exposure. It is man-made. You are exposed to the base stations anyway, involuntarily, all over, ubiquitously. You are not able to perceive the exposure yourself, and somebody is making money. These are all shown to be features that increase the fear factor. But still, the reactions by some people, alarmists, activists, and making this a major political or policy issue is unexpected to me, because there is very little evidence that there are any health risks. Of course, it's always possible. In health risk assessment, we say that it's never possible to show that the risk is zero. We can always diminish it and show sort of with smaller margin that the range of credible risks are this and this narrow, but to prove that there is zero risk, that is impossible. Okay, so this is what I had to say about mobile phone and health risks. I hope you were able to hang on and get an understanding about the perspective from epidemiology. But I can take now any questions that you might have. I'll try to find the questions, if there are any. Nothing in the chat that I could see. Okay, is there any behavioral effect? That's sort of outside my area of expertise. No, well, yeah, all I can say is, yeah, it's outside of my expertise. Nothing major that I could have been able to say. There have been studies in rats, for instance, and there are some controversial results suggesting that actually learning might be improved by RF exposure, but the evidence is not really that solid. Okay, another one. If the risk of 5G is not 0%, what is the worst case scenario? I think the largest risks that have been ever reported for any mobile phones have been the benign tumors, 2.5, but that risk, and those are very rare tumors, those would be affecting like 1 in 5,000 people or something like that. So that is the largest risk coefficients that we've seen. Personally, I think that even if we would be able to show definitively that okay, if you use a mobile phone, your risk of brain tumor, which is otherwise 1 per 5,000, will be 1 per 4,000. That would not affect people's behavior, because they are. Nobody can imagine living without a mobile phone these days. That seems to be a fact. How would a wearable device using 5G network possibly affect the health of the user's eyes and or other organs? That's an interesting question. Basically, yeah, the eyes are also an organ that is sensitive to heat, particularly the lens of the eye. So if there would be heating effect on the lens, that might increase the risk of cataract, lens opacities, but this is just speculation. Anything else? Well, if there isn't, then I'll just thank you and apologize for any technical issues during the presentation. Okay, there's still one more. Was there any study done to study the effect people are living on mobile towers or some base stations? There are a few studies. There's one good study conducted in the UK that only assessed childhood cancers, and didn't find any indication of increased risks. There are many poor quality studies that really cannot be taken as serious evidence. But the short answer is no, there is no real evidence for increased tumor risks due to mobile towers. And as clearly you would expect, the exposures being so much lower than from the mobile phone, that it would be unlikely that there would be effects. But yeah, as I said in the beginning, nowadays that the mobile phone power output is very low, they are actually not that much above the Wi-Fi levels. So if there is any effect, currently the Wi-Fi is very important form of population exposure. So it might be even as important as mobile phones. And knowing that everybody is exposed all the time, it will be very difficult to study if there is any effect of Wi-Fi, because there are very few non-exposed people. Everybody is exposed more or less to the same extent. So that would be very, very hard to spot if there is an effect. What is your opinion regarding radiation exposure to children, since they are now 1 year old when they start using those? This is, I skipped, there is only one study about brain tumors in children, and that showed an odds ratio about 1.2 with reasonably large confidence interval. Very little evidence about whether there's a risk. There are some theoretical concerns that ionizing radiation, which we know does cause cancer, that's beyond doubt. We know that the risk from ionizing radiation are larger for exposure in childhood compared with adult exposure. So that is maybe the main reason for concern. And then, is there a possibility of an effect that can surface after a long time period? Definitely. What we know about other agents causing cancer, it takes at least 5 years, easily 10 years, sometimes as much as 20 years to see an increased risk. Cancer development is a slow process. It's a multi-stage process, so that we can be quite certain that it would not be seen in a short period of time. And nevertheless, we can never be certain until we have evidence for a long period of observation time. And that is why one more reason why we need to be a bit cautious. Okay, I think I have used the time allotted to me, and so I just thank you for your attention and your questions. Have a nice hack.